Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, our topic is Colombia, the South American country that has weathered one of the world's most severe COVID-19 outbreaks. I speak to Professor Antonio Trujillo of the Johns Hopkins Bloomberg School of Public Health. A health economist, Dr. Trujillo has recently published an article in Lancet Regional Health Americas about the value of testing, tracing, and isolating individuals with COVID as part of Colombia's response to the pandemic. Let's listen. Dr. Antonio Trujillo, thank you so much for joining me on Public Health on Call. How long have you been working with the government of Colombia to combat COVID?
Thank you, Dr. Sharfstein, for inviting me to your podcast. I've been assisting the government of Colombia for the past 18 months, mostly in the design and implementation of policy to combat COVID-19.
What's the situation right now in Colombia?
Well, the cumulative situation is that we have 5 million cases, 120,000 deaths. It's a higher death rate, around 2,000 per million. The situation now is that we have around 2,000 cases, which is 5 per 100, which is low. It's an endemic, not a pandemic. But the forecast is that these numbers will go up and the government need to be ready for the new peak.
What's the situation with vaccination now?
Regarding vaccination, the government have around 23 million fully vaccinated, which is around 50% of the population, doing around 400,000 per day, which is a good capacity, going up to 1 million. Right now, it's 450, 500 per day.
So it sounds like it's been a very difficult pandemic, right now in a good spot, but trying to prepare, get as many people vaccinated and prepare for potentially more waves.
That's exactly right. The government have two efforts. One is guarantee that the supply and reducing the friction to increase vaccination. On the other hand, keep doing, the test, the trace, and improving medical care.
Yeah, so let's talk about the strategies that Colombia has had, because even though it's been such a difficult pandemic, in some respects, Colombia has fared better than some of its neighbors. So what's one example of a major strategy that Colombia has used?
I will say that before the vaccine was available, there are three strategies. The first one was improving the non-pharmaceutical intervention, the use of masks, the social distance, the lockdown. Very costly intervention, but as the supply was not enough, they had to do, like all countries, act rapidly to do the non-pharmaceutical interventions.
So there were lockdowns in Colombia?
Definitely so, and very costly, very difficult to implement. They close, they open, and they close again. They have to learn how to do the closing with the support of the state more smoothly over time.
And masks were pretty common?
The use of masks, this is a very difficult policy to implement. The use of masks, what you need to guarantee is that the masks were available, use social campaign, and monitor at the state level the use of masks. But definitely was encouraged, and still, even that they have the deployment of vaccination, there is a big emphasis on not putting the guard down, keep using the traditional public health intervention to reduce the spread.
Now, at the same time that the government was promoting masks, hand washing, distancing, it was working on expanding access to hospital care. Is that right?
That is exactly right. If I think about the three pillars that I mentioned at the beginning, second pillar, I'm not ranking them, but the three part of the tool will be at the beginning, before the deployment of vaccination, improving care, learning about treating patients, learning about reducing the deaths at the hospital, guaranteeing that you have the equipment, the medicine, what we call here the PPE materials to guarantee treatment so that the health system didn't collapse.
And were they able to increase the number of beds to handle the surges, or were the hospitals overwhelmed?
Well, that was a very important effort and investment that the government did. Just to give you a sense of magnitude, they moved the ICU from 6,000 available in the country to 12,000.
That's a big increase in intensive care unit beds. Did they all fill up?
Right now, they're not filled up because we're in a low season, but that's an important indicator to keep the other pillar in check. Reduce the fill out of ICU. The last issue is as you improve the deployment of vaccination, you're going to have cases, but you're going to have less cases ending up in the ICU. So right now we're at 60, 70%, which is a number that you wanted to keep at that level.
Did they ever get to a point where they couldn't care for all the patients?
That's what drives the lockdown, but they got a point where we have 90% of the ICU. And part of the regular monitoring in the policy room was, let me see this number, let's see where this number, before you get there, you have to motivate the lockdown based on that.
Got it. So they were able to avoid the worst case scenario, in part by taking extreme measures in different kinds of interventions. Now, the third pillar you talked about was called test, trace, and isolate. How did that work in Colombia?
Yeah, the other pillar is exactly that, improving your testing capacity, which is expanding your testing and respond quicker, then monitoring a case, call a case, make sure that the case is stayed at home, and provide certain primary care, public health. So they call this strategy PRAS. And the idea was to increase this monitoring and reduce the spread. So I really like to pay attention to this because most of the effort were in Pillar 8 and Pillar 2, and they were interconnected, but less effort into improving tracing, monitoring, and increasing the capacity of testing. And to me, that was key.
So it is easier to think about the need for masks and lockdowns on the one hand, and the importance of having enough hospital beds. The testing, tracing, isolating, that's a lot of hard work. How did Colombia do that?
They passed a legislation to secure that what they call there the sickness funds. It's like, imagine Medicaid, but many Medicaid, there are semi-private companies who insure the population, realize the call to the person who they identified, report a case. So they have to invest in this system to have the telephone call. So there is a big fixed investment in that, and then training the tracers and making sure that in rural places where you have less capacity, you have the tracers to visit the homes.
Do you know how many people were tested or traced in Colombia?
Yeah, that's an interesting question. The testing capacity increased significantly. So Colombia, in the peak of the COVID, make 100 tests per day. Right now, it is 42 tests per day, and reduce the tests from 7 to 8 days. As results of the tests in 7 and 8 days was not very helpful. So reducing that required a lot of effort. And the last issue I wanted to say, the sickness funds were able to move from just calling one person who had the COVID and one contact to covering up to 6 contacts of that person who report COVID. So that's a very important increase in capacity implementation of these test trace and isolate.
Got it. When you said they had a capacity for 100, do you mean 100,000 tests a day? Or?
Yes, 100,000 tests per day. Right now, they're in 40,000.
So a question that a lot of people have about contact tracing, testing, isolation is whether it works. And I understand you've done some modeling of the impact of this program in Colombia.
Yes. My first step was to make the case that if we do this investment, do we get a return out of this investment? So that to bring the attention to public health and public finance minister that investing in this effort will have a return. And that's what we tried to accomplish in the recent paper that we published.
And so what did you do in this research?
Traditionally, in public health, we're going to get a series of areas that have test, trace, and isolate, and at random areas where they don't have. We didn't have that opportunity. So in here, we have to be creative. And in the sense, what an economist tries to do is to show you the essence of the complexity and show the big numbers here. So what we did was a simulation, assuming that you have these test trace and with parameter, assuming how many less cases will you have in mild and severe cases, and how many less cases, if you do this, you're going to reduce in death. So using a standard parameter of the population, so, we had this SRI model to predict, how many people are susceptible, how many people will be infected over time. So we use these kind of parameters. We use assumptions and change the assumption to get a sense of how much money can we save and life can we save if we do this. So it's a simulation model rather than a quasi-experimental opportunity or an experimental intervention. But it gives policymakers the big sense, and this is what is important for me to highlight, the big sense of how many or how much dollars can you save if you put more attention into the test and isolate.
And what did you find?
So I found that the intervention save around $800 to $1,000 per case, reduce mortality significantly. And what is important is that these savings, sometimes public health intervention increase costs and save life. In this intervention, you save costs and you save lives. So it's what we call dominant. It's very good. So, and this is thinking about being very conservative in my benefits. I'm not considering a lot of benefits out of this. And the last issue that I wanted to say is the savings that you have here will be very valuable for future pandemic or for the deployment of other surveillance controls. So the investment that you do here will have a spillover over other investment in the future, and it will improve the productivity of the non-pharmaceutical and the medical intervention because you're going to reduce the pressure over the system. So I'm not counting that, and without counting that, reduce costs and improve health care outcomes.
So it sounds like you've shown a bright light on the third pillar and said, look, this pillar over here, the test, trace, isolate pillar, really makes a difference. How has that message been received?
I think the message has been received well. I think that there are not too many evidence that show there is a return on investment very high if we do this. Now, as usually in public health, the complexities are in the details. It's very difficult to implement this intervention, but highlighting the opportunities for benefit and the complementarities with other intervention, even with vaccination, was very important when I was thinking about this project.
Now, do you think that Colombia is going to stick with test, trace, isolate even now with the vaccine?
I think they should. I think I'm pushing for that. I think it's very relevant because, again, I see these three pillars as have a complementary. That means that if you improve the other, the return of the other two will increase. And even after the deployment of the vaccination, non-pharmaceutical intervention and test, trace, and isolate have a lot to help in the control of the pandemic.
Dr. Trujillo, thank you so much for joining me today.
Thank you, Dr. Sharfstein, for inviting me to your podcast.
Public Health On Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, and Matthew Martin with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holes Fernandez and Caroline Wong. Thank you for listening.